Okay, so this first case is a 19-year-old patient who had this, you can see they have bilateral hydronephrosis. They have this large, bulky bladder mass. And it's also involving the prostate. It's bulging the prostatic capsule here. Extending beyond the bladder. And then there's also some large lymph nodes, like for example, this pelvic sidewall node. And this is what it looked like on post-contrast. So avidly kind of enhancing large, bulky mass in a 19-year-old. So any thoughts?
A rhabdomyosarcoma?
Yeah, great. I recognize Omar. So yeah, this was a rhabdomyosarcoma. So a vast majority of these are going to be in children. Like 90% will present before the age of 15, but they can present in adults. In children, the more common type is this embryonal type and the botryoid type, which is kind of like a cluster of grapes appearance. And then the one in adults is a different variant that's a bit more aggressive. They usually undergo chemo and radiation and then eventually resection, but it can be very, very aggressive. So just wanted to show, so this wouldn't be that very typical for a urothelial cancer. And so if you have a younger patient, very bulky mass, think about a rhabdomyosarcoma. Okay.
Did this invade the prostate, or do you think it originated in the prostate?
Yeah, it's hard to say where it originated. So most rhabdomyosarcomas of the GU tract, they say are of the base of the bladder and or the prostate. So it's a little bit semantic. This one, I don't even know where the epicenter is. It's kind of basically the base of the bladder / the prostate. But I think there's something about that tissue there, and it arises from the submucosal muscular layer, because that's why the myo part, the rhabdomyosarcoma part. So yeah, I guess it doesn't truly matter to them which one it arises from, but basically it's usually the base of the bladder, which is why you can see like the top of the bladder is spared here. Okay, this is my next case. This patient had RCC. You can see they had a right nephrectomy, and they ended up having a met to the pancreatic head, and they ended up with a Whipple. And so this is the remnant pancreas here. And this is the jejunal loop. And I'll just kind of point this out to you because I just thought it was a cute finding, is that there is a subtle lesion here. And you can see it much better on a couple of other sequences, especially, for example, this autophase, where you can see a lesion with drop intravoxel fat within it at the pancreatico-jejunal anastomosis. So what do you guys think this is?
A met?
Yeah, yes. So this was a met from clear cell RCC. So just to remind ourselves that clear cell RCC can have intravoxel fat, and it can also, they like to met to the pancreas, which I haven't truly figured out why, but I think it's because it's very vascular, and it also has the receptors that will take an RCC met. This is something that we've seen in our practice a lot, but sometimes miss because it can blend in with the pancreas on other sequences. So for example, the arterially enhancing RCC met will blend in with the enhancing pancreas. For example, on the post-contrast, it's like kind of hard to see here. So one of the phases I find to be most helpful is the pre. So I always look at the pre, the diffusion, and the in and outs of the pancreas on any patient who has RCC. And here you can see that the pancreas is nice and bright. And then here is that lesion that is standing out as like this dark thing. And then we kind of confirm that there's this thing with intravoxel fat here. The reason that clear cell RCC has intravoxel fat is because it can be very glycogen rich. So it has lipid within the cells. And then I also found this article interesting. Let's see if I can pull it over. Oh, I lost the article. Okay, well, basically, anyway, I found an AJR article saying that, for example, if you have a lesion in the kidney itself and you're trying to determine if it's a clear cell RCC with intravoxel fat or a lipid poor AML, you can use a 20% signal intensity drop, and the clear cell RCCs will have more than 20% signal intensity drop. So for example, this lesion, although this is in the pancreas, so we were much more concerned for a MET, this lesion, when you compare it to the in phase, was dropping like, 50%. So it's more than that 20% signal intensity drop. Whereas lipid poor AMLs will tend to drop much less significantly, like, in the 10% or less range. So you can see this one had a lot of dropout. So the more dropout, the more likely it's a clear cell RCC. Okay. My next case is this one. This was a 50-year-old female who had this, you can see she's got multiple cysts in her liver and then had this very large lesion here. It had kind of these lacy septations. This was the T1 pre-contrast. You can see it's pretty T1 bright. The other cysts are not very T1 bright. And then on the post, it was a little confusing, so you have to go to the subs. And on the subs, all those lacy kind of septations don't really enhance. So what are people's thoughts on this? Would you call it a cyst, a mucinous cystic neoplasm? Would you hedge? Everyone is so quiet today. Any thoughts?
Mucinous cystic neoplasm.
Okay, why do you think that?
The lacy septations kind of give me some reason for concern. The size of the lesion, the T1 characteristics. I know that it doesn't enhance, but it could just be you don't have enough tissue to be able to register the enhancement that is present. So I would ask for an intervention for that.
Okay, good. So we did look at these septations. We were kind of, hedging a little bit about it, but a couple of the clues that I was favoring that this was a cyst is that one, the patient has other cysts in the liver. Two, the MCNs tend to be in like segment 4, the left lobe or segment 4 of the liver. This one looked kind of more like it was predominating in the right side, although you could say maybe it arose from segment 4 here. But it probably was coming from the right side. And then it really didn't have, and then the T1 hyperintensity can really go both ways. So when you have these complicated cysts, they can actually have a lot of hemorrhage and T1 hyperintensity in them. And then we didn't think that these were like true septa. So I guess the teaching point here is that when you get this complicated cyst, it can have like maybe fibrin and things in it, but it doesn't have true septa that are like true walls. So we favored that this was a complicated cyst and it was removed because it was symptomatically pushing on the liver capsule, and this came back as a complicated cyst. So not even a complex cyst because it didn't have any like dysplasia on the wall or anything like that. It is a complicated cyst. But if you are on the borderline, you can hedge about it because then they may not fenestrate it, and then they might check like a frozen section intraoperatively and be a little bit more careful. But this one was a complicated cyst. Okay, this was a cool mystery case. We were reading the MRI and we saw that this patient they were pretty asymptomatic. They had all of these lesions in their spleen. And you can see that some of them were very bright. They almost look like cystic. Others were kind of fairly bright, but had complexity. They were all enhancing. Didn't really see much else in the abdomen. There wasn't other lymph nodes or anything like that. But so we were kind of concerned, like this doesn't look like just a bunch of benign lesions. It didn't really look like literal cell angioma, which tends to be more hypoenhancing lesions. So we recommended, we brought up lymphoma, metastatic disease, and asked them to consider a biopsy. But the patient ended up getting a PET scan, which was interesting. So one, I guess, take-home point is that you can biopsy the spleen, and we've done that before. But this is the PET scan, and you can see that they've got these lesions in their skull, in their calvarium, that are a little unusual looking. So I kind of forgot about this entity because I think people see it more in neuro, but the patient ended up having an entity that they see where they get calvarial lytic lesions, and they can even sometimes get like orbital lesions. So anyone closer to residency have a clue about what could be causing, these calvarial lesions as well as these splenic masses?
Well, sarcoid and lymphoma can do anything.
Good,
That's
excellent.
what I always say in neuro.
Mm-hmm. Yep. So sarcoid and lymphoma. And then because of these lesions, somebody brought up myeloma. This patient ended up getting a bone marrow biopsy, and it was totally normal. They did not think the patient had myeloma. Anything else?
Langerhans histiocytosis?
Yes, Omar, you're on a roll.
Yeah.
So this is what used to be called histiocytosis X, and is now called Langerhans cell histiocytosis, which there's that lumps together three different types of histiocytosis. So basically, the take-home points are that histiocytes are normal cells in our body, but some people, due to some immunologic derangement, will start hyperproliferating histiocytes, and then they can deposit in the bones and also in other organs. It's much more common in children. And when you get it in the spleen, it's usually systemic, so it's affecting multi-organs. This patient also had a mediastinal mass. None of these things were very FDG avid, and so it would have been quite atypical for lymphoma. I don't know why this is looking so weird, but anyway, so anyway, this patient ended up having histiocytosis X or Langerhans cell histiocytosis. So for example, you can see there's a mediastinal component that wasn't very avid. The spleen was not very avid, so that would be very unusual for lymphoma, etc. So I just thought this was cool. Interesting finding. This is a companion case to one that Manjul showed last week. So he showed a sciatic notch mass. And I also here have a sciatic notch mass. You can see it looks a little different than his. It looks like it's going through the sciatic notch, but maybe there's like a multifocal kind of component to it. It's a little bit more infiltrative rather than looking like that dumbbell shaped one that he had. Manjul's case was a schwannoma, mine is not. And then this is the post-contrast. Fairly enhancing, growing in multiple directions. Last week, Nellie had brought up an angiomyxoma. Those tend to be more going into the ischioanal fossa here, rather than through the sciatic notch.
Fibromatosis.
Yes, good. So that's what this was. So this was what also is called desmoid, but the better term is aggressive fibromatosis. So you can get these anywhere. Patients with Gardner syndrome, FAP tend to have them more commonly. And then, they can be in these sometimes unusual locations. Just because they're fibrotic doesn't mean that they're T2 dark. And in fact, they can be fairly T2 bright and have this kind of bland, dense enhancement. And they can grow in a kind of like infiltrative pattern as well. Due to symptoms, this one was actually ablated by one of our IR docs. Okay, my last case, there is this mass here. It has, on the CT, you can see it's got some calcifications. It looks maybe centered around or in the adrenal gland. This is the T2. not fully encapsulated. Arterial, it's kind of got mottled enhancement. Some delayed enhancement, that's the delay. This is the venous. Any thoughts? Does the calcification help you at all? Does the T2 help you? So we were thinking either a pheo or an adrenal cortical carcinoma. The clinician said the patient was very hypertensive and so was favoring a pheo, but we were favoring a adrenal cortical carcinoma. And one reason was it wasn't super bright, although only 40% of pheos are light bulb bright. And the other reason is that it looked like maybe it was even growing into like kind of growing along veins. And then the other big reason was because of this calcification here. So you can get calcifications in both, but they're much more common in adrenal cortical carcinoma. So anyway, this was biopsied and it was an ACC. So one other thing about ACC, so one, they have much more commonly have calcification than a pheo. And another thing is that don't get deterred by the hypertension because they can present, they can be hypercortisol producing and also give you metabolic syndrome and hypertension.
So my case is not gonna be very difficult, but it's a case that I wanted to share.
Yay. Sorry I disappeared. My Zoom crashed, but I'm back. Okay, go ahead.
One moment, please. Can people see my screen?
Yes.
Yep.
Okay, fantastic. So again, as I said, this is not a very challenging case, but a case that was instructive, and I wanted to share with the group. This was a 66-year-old male with alcoholic cirrhosis and long-standing history of hepatitis B, and this was a MRI that was performed for evaluation of hepatocellular carcinoma. And fortunately for the patient, there was no hepatocellular carcinoma, but there were in and out of phase imaging. On in phase, you can see there are multiple areas that there is decreased signal, which is not present on out of phase. These areas do not show any enhancement. And do people know what this is?
When you say they don't show enhancement, they must have some enhancement, but you're saying it's hypo enhancing compared to?
They're iso to the liver. They're not hyper enhancing as would be expected for an HCC.
Yeah. Is it like a siderotic nodule?
Yeah, these are all siderotic nodules, and it's extensive throughout the hepatic lobes. It was an interesting case, so I wanted to share it with the group.
Yeah. What is that? Is there also like a fat containing one, but that seems to like not really enhance?
Is this what you're referring to?
Yeah.
I think that was a cyst.
Yeah. It's
It was
interesting
a
that it
cyst
looked
or a
like
hamartoma.
yeah.
But that one I knew what it was, but these other lesions, I didn't know how to evaluate them each, and you don't need to evaluate them each individually as long as there's no enhancing or washout on the dynamic contrast enhanced images. Those are just those you can say innumerable siderotic nodules within the hepatic parenchyma, and that this patient will get follow-up and will look in these regions for any lesions that may develop over time. So that was my case.
Cool. Do you guys know, like anyone else out there know if siderotic nodules have a higher rate of developing HCC? Or
So when I was looking into this, they don't have necessarily a higher rate of getting HCC, but there's so many nodules that, like, if you were looking back at 8 examinations and everybody kept calling it siderotic nodule, the point is to still look carefully, because in that area there could be an HCC that develops. There is a significant amount of the liver that has these nodules in it, so you gotta look at this and see if something new comes up there.
Cool. Anyone else have cases? Okay, we will end early. I saw Steve unmute.
Well, I'm going to share this case. I'm disappointed that I don't have path on it. Last time I checked, there was no path, but I think it's a decent lesson for us, and I'll explain. So I'm going to share my screen and show you it.
Okay. Yeah. It almost looks like a modified because they're taking like a video or something.
Yep. So this was with the speech pathologist, and it was a patient that had kind of a chronic globus sensation or difficulty swallowing. And on the early sets of images here, not much to see unless you're really astute, maybe.
There's prevertebral soft tissue on or retropharyngeal, possibly.
Teresa, we can't hear you well, but did you say something about a retropharyngeal soft tissue?
Yeah, that's what I was looking at.
Kind of looks like that. Something that's you keep on seeing right around here, right?
Mm-hmm.
Something you keep on seeing. It's pretty subtle.
Further.
Good call.
Here's I think this might be the barium pill, or this is the barium pill. I got to go back to the beginning, but notice that the barium pill kind of gets stuck there. I got to go backwards though. I ended up in that. Here we go. So it kind of gets hung up there. And you almost with the gas can see the outline of something there.
Is it histiocytosis?
No. I don't know what it is. I told you. And then on the frontal, maybe not this swallow, but the next one with more volume, I think you can sort of see that.
Do you have an MRI?
No, I have a CT.
Oh.
I think it's a CT. Yes, CT. Let me make. This is bone. Let's go to soft tissue. And so there it is on CT. And the guy's kind of lost to follow-up. So, you know, it's a differential of it kind of looked like it was maybe intramural or extramural. It didn't really look like it was, you know, causing a lot, destroyed mucosa or anything like that. And so I guess it could be something benign like leiomyoma, which are not too uncommon, I think, in the esophagus. It's obviously not a lipoma, but that could have been true, and maybe we would have seen it a little differently on the 2 studies. And but he's not come back to get. I think he was supposed to see ENT and missed his appointment, so I don't really know what it is. But it's just a lesson of not to fall asleep at the wheel at your speech pathology exams.
Yeah, that's cool. I definitely also favor a leiomyoma, like, or maybe a GIST, something round, extramural, submucosal kind of thing.
Yeah.
I also noticed that a lot of my patients that I've been following up have been lost to follow-up recently, and I don't know if it's because of COVID or just, you know.
I wonder if that's, COVID related. You know, people are a little bit reluctant to pursue care for things that aren't bothering them too bad.
Yeah.
So.
Cool.
All right.
Okay, I think we're done. Have a great day, guys.
I got to tack that one on. Yeah.